occurred for this session, but please don't put your phone on hold, just in case something does go a bit haywire with the audio. For everyone that's been in these webinars before or used GoToTraining, it's pretty standard, but for anyone else who hasn't, there's just a quick slide of how to hide the panel. If you've got any questions, if you can put them in the chat box and we'll get to them as we go along. But if we're unable to get to them, we'll get answers back to the group at a later stage. And so we've got an idea of how many people are actually listening to the webinar this afternoon. If there's anyone else in the room with you, if you could just put their name, their title, their email address and the organisation, again into the chat pane, so we can have a complete record. So thank you very much for doing that. And now it is my pleasure, let me go to the other slide, to introduce you and hand over to Dr. Andrew Knight, and our special guest speaker is Dr. Chris Bollen. So thank you, Andrew. I'll mute myself and now hand it over to you.
Thanks very much, Alison, and thanks a lot for your support to us all here. Bit of an echo for me. Anyway, I'll press on. These lunchtime sessions are proving very successful. The format where we take half an hour at lunch seems to suit people in general practice. The half hour lightning lunch, Tony Lemke calls them, and it seems to work. Alison, I'm getting quite an echo on the phone. I don't know why that is. But, anyway, but we're very happy to have Chris with us. I've known Chris over a number of years. He's been very involved with the collaboratives over the years, and maybe I'll just hand over to Chris. Maybe you give us a very brief introduction to yourself.
Oh, thanks very much, Andrew, and hello everyone that's online today. I'm a GP here at Oakland Medical Centre, which is in urban Adelaide, and been a GP for 25 years, but over that time I've diversified my interests. I've been involved in a public hospital as Director of GP Training, and I've been CEO of a division for about 7 years, but continuously, loves to get involved in things where we can improve healthcare. And so a lot of my different roles in life now are about that, and one which is dear to my heart is I've been involved with Kidney Health Australia in the last 12 months, and that's been fantastic seeing the improvement in Australian community, general practice, and the rest of the profession in knowing about chronic kidney disease, which is a very underrated area.
Mm. And for those of you who don't know me, I'm a GP as well. I've been a GP in Sydney, New South Wales over the last almost 30 years. I'm currently at an academic unit part of New South Wales Uni where I still see patients, and I've been involved with the collaborative since they began over the last 10 years. All right, Chris, we're going to talk about chronic kidney disease. Thanks so much for your time. And I think we discussed the idea that we would approach it as we do all improvement topics. So we're actually going to approach it through the lens of the 3 improvement questions. And those of you who've been, I'm sure you'll be aware of all these. So the 3 questions we ask ourselves when we're trying to improve something is, what is our aim? What are we trying to achieve? How will we know we've made a difference? What measures will we collect? And then finally, what ideas do we have that we think will make a difference? And those are the things that we test in small rapid improvement cycles. And so we're going to wander through this topic using those headings because we find they're very practical in terms of implementing change in general practice. But Chris, one of the things that I didn't mention to you when we talked about this last week was, of course, you have to start with defining the problem. Before you can set an aim, you need to know what the problem is. But I think you can probably talk to that fairly easily. When I started in practice, I think I said to you, I used to see these creatinines come across the desk that were high, especially for my older patients, and I just sort of notice it and do nothing about it pretty much. But in the last 20 years, 10 years, there's been a big change to that. Can you talk to us about the problem that we're addressing before we set the aim?
Yeah, I think it's really good because chronic kidney disease, the awareness raising is such a big thing. Because you're right, many of us have seen these creatinines have been a little bit up, and now that we're seeing this other concept of the electronic or eGFR, the calculated glomerular filtration rate coming in on our blood tests, it now actually gives us a much better handle on what's truly going on, what this slight elevation of creatinine really means. So what chronic kidney disease is defined as a glomerular filtration rate of less than 60 mils per minute. And it needs to have been there for more than 3 months to actually been seen as chronic kidney disease. And that's the slide's up there now. So that's number one. Or you've actually got some evidence of kidney damage as a result of some sort of anatomical abnormalities, that something's happened to the kidney, so you've had a partial removal related to a tumour, or you've got blood in the urine that's been, once you've had bladder cancer and other stones and other urological causes excluded, you've got to say, well, if you've got blood in the urine, there's some other sort of kidney disease there. And then, of course, the thing we see a lot of in general practice, protein or albuminuria in the kidney, in the urine itself. But going back to that GFR, that's the critical thing we're seeing pretty well on a daily basis in general practice when we see our electrolyte, kidney function, blood tests coming back, and different states call it different things, MBA 20s, SMAC 20s. They've all got this eGFR on there now, and it's a critical thing to have a look at, because sometimes we actually see a low GFR. So let's say we see an 80-year-old with a GFR of 50, but their creatinine can actually still be in a normal limit. Now, they actually have chronic kidney disease, even though their creatinine level is normal. It's really important to think about, because the function of the kidney and this filtration rate relates to age, sex, as well as the creatinine. So that's in a nutshell, Andrew. Hopefully that makes some sense.
Yeah, look, I think that was an absolutely brilliant system change that I think the Kidney Foundation was very involved in implementing at the time, was the introduction of these eGFRs, so the calculated GFR. So suddenly we had an idea of what was happening with our patients' renal function. That's great, Chris. Okay.
Just to add on that, I think a really good thing for our sort of people on the webinar to think about, because creatinine is this, well, it's a number of something. Now, knowing about filtration rates, think about your kidneys and your filters. The whole consequence of chronic kidney disease is your filters aren't working properly. And if your filters don't work properly, the blood's going through the filters, it's actually taking out the bad stuff and weeing it out. If essentially your filters aren't working, then your toxins are building up in your system. So that's getting back to tin tacks of how we explain this to our patients. If we health professionals understand it in those terms, which a lot of people haven't necessarily got to grips with, if we know that our filtration rate is poor, then the toxins are building.
Yep. Makes sense. And that's the sort of practical conversation we need to have with our patients all the time. We need these scripts to describe them, don't we? Okay, so that's the problem. How big is it, Chris? Is it a big problem or a small problem? Is this something that we, there's lots of problems we get asked to deal with. Why does general practice need to change and deal with chronic kidney disease when we haven't necessarily before?
Well, it's humongous. And, I guess, look, so much effort has been put in this country to raise awareness of diabetes and heart disease, but chronic kidney disease is linked to both, and in total, it's just as big an issue. So on the screen there, you can see that 1 in 10 Australians actually has chronic kidney disease over the age of 18. And so for many people, blown away to think that that's the size of the problem. But only, around about 1 in 10 of these people will actually ever have known, because a lot of people are having blood tests, and you look at all the people that have blood tests for their diabetes, annual checks, and other health checks. But people often don't make mention, oh, by the way, your kidney function might be a bit on the downside. So that 1 in 10, it's huge. 10% of the Australian population has chronic kidney disease, and most are unaware, and most of their health professionals are also unaware, which is a double whammy.
Okay, so it's something that has come to our attention more recently. It is a big problem, and it is our problem undoubtedly in primary care, where the difference can be made. Let's think about the aim. If we, in our general practices, we're aiming for something. What are we trying to achieve?
Well, in this situation, you know, if there's a short and a long term. A long term, why do we get fussed about chronic kidney disease? Is because, you know, if that kidney disease is actually not recognised, then it deteriorates over time, and that deterioration of the kidney disease then leads, in the long term, end-stage renal failure, which leads to dialysis, and potentially kidney transplants might be an option, but kidney failure, dialysis, and death. So it's over a long period of time. So this is a classic example of why we do something different in general practice, just like early interventions for diabetes, where we pick it up early, we manage it along the way in conjunction with our patient as an incredibly important part of the team, and our team in the practice. We can actually make a huge difference and slow the progression of the disease. So that's why it's so important, because if you do nothing, then the inevitable happens. You end up with worsening kidney disease and kidney failure, which requires dialysis. It's not a good result for anyone.
Yes, I get that. That's the big agenda. We want better outcomes for patients, less kidney disease, less morbidity and mortality related to kidney disease. But that doesn't help us in the practical management of our practices. We need to be setting performance aims for our team. What sorts of aims are we going to work on? You know, when we've got our community, our practice nurses or our GPs or our practice managers, and we say, look, you've got to aim for this. What are we going to say to them?
Well, we need to identify the people that have chronic kidney disease in our population, in our practice populations, because currently, you know, we don't know who we don't know. Yet,
okay,
because in our practices, we're already doing a great job with diabetes and high blood pressure and those sort of things. We actually know these same people, but for some reason, we haven't actually thought about, do they have chronic kidney disease? So our aim is, let's look at those people that are high risk in our practice populations and identify them.
Okay, so that's an aim. Identification is an aim. So if we were to state that as an improvement aim, we would be saying something like, I don't know, would we be saying, you know, by September this year, 100% of people in the at-risk group will have had a eGFR estimated and those with a diagnosis of chronic kidney disease will be recorded in past history, or 80% or 50% or something like that. Is that a sort of aim would be having for identification?
Exactly, because then if you're actually, you're at-risk group and you actually go through your practice population, thinking about what they need, get that eGFR done and identify, you are making a huge difference in your practice population. So for an improvement goal, it's a big one. It's obviously in your practice, but it's a really important one.
And it's unlike some of the other diseases, well, it's a bit like diabetes, but other diseases where the diagnosis kind of gets handed to you. We know with chronic kidney disease, it's a misdiagnosis in what you said, 90% of people who've got it.
Exactly. And so for many of these people who are at high risk, they will actually have already had the blood test done for some other reason within the last 2 years. So you've actually already got lots of information in your practice databases that you could be using without actually even having seen that person. So that's a really important thing. So then you can actually arm your practice team to be on the alert for this group of people every time they come in for a care plan, or every time they come in for their diabetes cycle of care, or every time they come in for another reason, be on the lookout for people who've had a blood test.
Okay, so all you practice managers out there, all you chronic disease nurses, all you GPs who are managing your teams, you could put identification in there as one of the aims that your team will have if you are going to start working on chronic kidney disease as an improvement field. But Chris, okay, you got them identified, that's just not enough, is it? You've got to go on and actually manage them optimally. What sort of aim are we looking at there? What sort of aims are we looking at there?
Well, look, if you think about what are the things that cause the kidney disease to progress. So if if your blood pressure is not being treated to target. So we really need to aim for, a blood pressure of better than 140 over 90 for this group to try and reduce the progression of kidney disease. So that's probably your number one target. But there are a number of other targets. When you think about the risk factors for developing chronic kidney disease, they're the same things we need to be actually doing to manage the person with chronic kidney disease. So diabetes, if their diabetes is poorly controlled, diabetes is a risk factor for their ongoing chronic kidney disease. So we need to get good glycemic control to actually improve their chronic kidney disease. Thirdly, obesity is actually a risk factor for chronic kidney disease. So losing weight, getting fitter, improving people's muscle mass is actually significant for managing chronic kidney disease and delaying progression. And a really important one, which is often forgotten, is have a good look at the medications that people are taking, because there are many medications which are renally cleared through those kidneys, through those filters we were discussing, and if they're on medication which is cleared through the kidney that then it builds up, it damages the kidney even further, causing that creatinine to increase their GFR to decline. So they can feel unwell because of the medications they're on. And common ones are anti-inflammatories. Your over-the-counter non-steroidals, as well as your prescription ones, which are hugely prescribed. They are ones doing damage to those people's kidneys. So a medication review is probably a really good aim if you're thinking about what can the team be doing for an improvement. Linking a group of people with chronic kidney disease to have a home medication review would be an outstanding improvement aim in your practice.
Mm. Okay, so we've talked about aims. One aim is symptom identification, which is particularly important in CKD. We've talked about reorganising our systems. The aim is to get people having appropriate care in our practices. The measures I think that we should be looking at in our practices then fall out pretty easily. There'll be a measure around your register, how many people are actually on your register. There'll be measures around people on the register having their blood pressure controlled. You may look at the weight, the BMI of people on your register. You might look at medications of people on your register. These are sorts of measures which are actually available, I think, on QI Connect. So those of you who are using, you can look at them through QI Connect if you're reporting data, which I hope you are. But alternatively, within our practices, we can use the extraction tools. The canning tool will do it, and so will PenCat. You can use them to extract data and look at data within the practice around CKD. And there's a suite of these tools which are exactly along the lines that Chris has talked about, so that when we can measure our quality and start to make improvements with the team. So Chris, we're moving through the time. I told you half an hour would go very quickly. Ideas that make a difference. You've already raised some. You've mentioned medication review. You've mentioned diabetes treatment, weight management. What sorts of things could we be looking at when practices are trying to make a difference to those chronic disease markers? What do you have some ideas of what people have used? And in a minute, guys, if the people listening, I'm going to throw it to you because I know many of you have worked on chronic kidney disease. If you've got some things that have worked really well, I'm going to ask you to throw them up on the chat pane as well. Chris, what are your thoughts?
Well, going back to blood pressure control, so one way is linking a number of people with chronic kidney disease that are on a ACE inhibitor or an ARB, because that's a really clear link between disease and something that has evidence to actually slow progression. So a bit like the heart disease sort of improvement ways where you link people with beta blockers and ACEs. Same thing here. Trying to link an improvement by, we've got a condition and this is actually an evidence-based treatment for it. So that's just an idea. But yeah, certainly be happy to hear from others about what they're thinking about in their practices for improvement in this area.
And we've got a comment from Jane Bollen. Relative, Chris?
Yep. So,
have you seen the comment?
I can't actually see my comments.
Okay. Well, what Jane's written, those you can probably see it. She's mentioned cleansing cat that you can use to pick up your patients with CKD in whom the diagnosis is not recorded. So, cleansing cat seeks to use a number of markers in your EHR and say, hey, this person looks like they've got CKD. I suppose they've got a high EGFR, or there may be other markers. Maybe you've recorded some urinary abnormalities, and it's flagged this person as having CKD and said, but you haven't recorded. Is this reliable? Now, I don't know the answer to the question. I bet you someone out there does. Has anyone used Cleansing Cat to do this, and do you have a comment on it? Or Chris, do you have a comment?
Yeah, I actually have. I work with a practice that has done this. And interestingly, because basically we think, oh, it'll pick up everyone with chronic kidney disease. What it does is it actually looks for those that have got a EGFR of 45 mils per minute or less. And that's actually an important number, because that's actually chronic kidney disease stage 3. And it starts at 45. Less than 60, from an earlier slide, would have said that's chronic kidney disease. But what it does, it seems to pick up those that are 45 mils or worse per minute. So it may not pick up your stage 1 and 2, but it'll start stage 3. So from a reliability factor, I think that's an important one to just look at.
And how was it in the practice that you did it with? Did they identify many patients who clearly had CKD that they hadn't recorded a diagnosis in?
Yeah, huge numbers. So basically they they went from a percentage of their population of people over 75, they ended up having around about 19% of that population with a coded diagnosis. But they probably started, I think about only 5% of them had a coded diagnosis at the start of their improvement methodology.
Now, we've all got different practices, different demographics. Some of us have a lot of older people, some of them don't have. What common percentage of people over 75 with CKD? Like, if we've only got 5%, of our practice population, we might be thinking, we haven't got it quite right. Yeah, there's some figures.
Yeah, and that's right. I think this slide sort of tells lots of the prevalence sort of slowly increases, and it really hits home when you get to 65 plus, and then that's 40% of all of 75 and over that are in your practice population. So when you've got that bigger percentage, known in the community, but if your actual practice numbers for 75 plus are in the 5% or so, then you've got a lot of work to do. It's really interesting having conversations in practices about, well, why do we need to do this, Chris? Why do we actually really need to be coding chronic kidney disease for this group of people? And, because what a lot of the doctors say, I know they've actually, their creatinine's not as good as it could be. I'll say, well, you're a teaching practice and you've got a registrar who doesn't know much about chronic kidney disease, and that doctor is actually prescribing something because they haven't been able to get in to see you, the usual doctor. You have left that doctor wide open for making a really big error of clinical care. And really, we've got to do safe care in our practices. So this is a really important one. If we know that chronic kidney disease leads to dilemmas with prescribing, then everyone who's a prescriber in this practice needs to know what the chronic kidney disease status is of every patient in your practice. So that's a really important one when it comes to safe care in our practices.
And thanks for the comment, Barbie, that you're using the pen audit to flag to doctors the patients who have CKD, and you do that monthly. So I presume that's part of a suite of monitoring measures you do to maintain that register. So absolutely key activity for CKD is this regularly maintaining your register, because it's only after you've identified the patients, as Chris has said, that you can start to intervene, and it'll flag to doctors not to prescribe the nephrotoxic drugs, and to be more to have less inertia with regard to managing their blood pressure and so on. And Michelle's made a question, Chris. I don't know if you can see Michelle Guppy's question there, but 42% of people, they don't all go on to end-stage renal disease. Only a small percentage will.
Okay.
All this effort for 42% of your patients over 75 have got it, and huge effort, and only a very small percentage of people will ever suffer morbidity. Is that correct, or how would you respond to that question?
So there are three sort of issues here. So essentially, remember, in the time it takes to get from development of chronic kidney disease and end-stage renal disease may be in the order of about 30 years, Andrew. So most of those 75 and overs that we're talking about aren't going to last 30 years. that's a really important sort of fact. So not all. So end-stage renal disease isn't the only issue here. Clearly, if you're 45 and you've got chronic kidney disease, then those numbers start adding up a bit more. You know, by the age of 75, most of them will have end-stage renal disease. So the age when it's actually diagnosed is important. But going back to, so end-stage renal disease is one thing, but every person with chronic kidney disease has a hugely increased risk of myocardial infarction. So their cardiovascular risk is multiplied many, many times once they have chronic kidney disease. And that's actually something that most people are unaware of. The link between cardiovascular disease and chronic kidney disease is actually intertwined. And so every one of these people that has a diagnosis of chronic kidney disease needs to have their lipid profile looked at and blood pressure and all of their usual cardiovascular risk assessed, because they're at high risk straight away. So, you know, using the cardiovascular calculator that many of us are using, you don't actually need to use it for this group because they're already in the high risk group once they've got chronic kidney disease.
Which just goes to show, Chris, that all these diseases, as we find the heart disease, diabetes and the chronic kidney disease, they all start to converge. Look, it's 1:29. I'm aware that we've used our time and we need to keep faith with our lightning lunch. Oh, Alison's saying we've got 5 minutes left. Is that right? I think we've already got some people leaving, so we really don't have much longer.
Okay.
I guess, Chris, is there any last message that you want to say to the group before we finish up?
So I just thought there's a little question here. I can't see who it's from, but a pathologist told the person that EGFR is affected by dehydration. Going back to chronic disease, it's a diagnosis that is lasting more than 3 months. So if you actually have a one-off abnormal EGFR, then repeat it in 3 months to see what's, you know, because of course dehydration, summer, all those sort of things, to see whether it's a consistent reading. If it's consistently there, it's chronic kidney disease. Full stop.
Great answer. Thanks, Barbie, for the question. It's a really important part of identifying patients is to have confidence in the diagnostic testing. And another question from Jane Bollen was to Barbie as to why would you not mark stage 1 or 2? Chris, I don't know if you want to comment on that.
Oh, well, you would mark it because the risk of you know, once that EGFR goes below 60, it's a march. It is a progressive disease. So, like anything, you know, or you know, when the old days of saying a touch of sugar, complacency sets in. If someone's got chronic kidney disease, they're on the march. We need to make sure that everything is done to prevent progression. So you must mark it. So the pen cat and the cleansing cat unfortunately doesn't pick up that stage 1 or 2 as I'm aware of unless something's changed. But yep, it's fundamental to pick it up early.
So great comment, Barbie. You're way ahead of most people, but you might like to think about that stage 1 and 2 and whether there's some way that you can start to pick those up. I think we've used our time, so Chris, I'm going to say thank you very much to you for taking your time out today for our lightning improvement lunch. Just taking us through a very quick skate over the topic of chronic kidney disease. It's certainly something that has been addressed in the collaboratives. If you want to look at QI Connect, if you want to look at your data extraction tool, you'll find measures that you can use. And I guess we'd encourage you all to put it on your agenda, put it on your work plan, your quality improvement work plan. Once you've got on top of what you're currently working on, maybe you need to think about moving on to something else useful, and chronic kidney disease would be something well worth your consideration. I might.
One last comment, just to sort of for some of our viewers, is that on the KCAT website, the kidney disease KCAT in general practice book is there, and it's like the diabetes standards from the college. It's the same sort of format. It talks about the practice nurse role, the GP role, how the team can actually do a great job together. So I just encourage everyone to go to KCAT's website.
Brilliant. Thanks so much, Chris. Alison, I might hand back to you. I'm sure you're going to ask people to be very diligent about filling out their evaluation forms. And I just want to thank you all for participating in our first QI Connect Lightning Lunch. These things are a great way to keep us focused, keep us connected, and keep us with quality improvement in mind. So over to you, Alison.
Thank you very much, Andrew, and a very great thank you to Chris also. That was an insightful webinar. As Andrew has said, evaluations are always important to us. So at the completion and as you log out of the webinar, if you could fill out the evaluation, that would be greatly appreciated. And if, just as a reminder, if you haven't done already, anyone else that's in the room with you, can you just add their names to the chat log? Thank you to everyone that's participated in today's webinar, and we look forward to seeing you for the March webinar with more details coming shortly. So have a lovely afternoon. Andrew, Chris, again, thank you very much for your time. It has been a great discussion. Bye, everyone.
Andrew, Alison.
Thanks. Okay, bye all.
Bye.
Bye-bye.